Okay, we're back to video number 2. I hope you had a chance to review PICO questions in your small groups. We can go over some of the possible PICO questions that you could have come up with. Let's look at the bath basin case study. So one PICO question you could have come up with were the P could have been post-op patients, intervention, dispose of bath basin if used for emesis, compared to using the same bath basin even after exposed to emesis, and the outcome is decrease infections in the post-op patient. That is not the only PICO question you could have come up with. Here's another example. You could have come up with the P being all patients, not just post-op, but every patient in the healthcare system. Intervention, clean basin with chlorhexidine prior to bathing, compared to cleaning it with soap and water, which is a current practice. And the outcome, again, decrease infections within the health system. So that is a possibility. These case studies really did come from PICO questions from previous evidence-based practice nurse residency projects. Blood culture contamination case study. So one PICO question possibility would be the P could be patients in the acute care setting, intervention using a sterile process compared to using a clean process, which is non-sterile, and the outcome, decrease blood culture contamination rates. That is one option for a PICO question. Another option for a PICO question for the same literature could be, the P could be emergency department patients with blood culture orders. The I is having phlebotomists draw blood cultures. The C, compared to RNs and techs drawing blood cultures. And the O is decreased blood culture contamination rates in the emergency department. So this could have been one of your PICO questions. This really was a nurse residency project, and we do have phlebotomists at the plaza in the emergency department drawing blood cultures. Our next case study, the healthy food options. So one option for a PICO question could have been, your population could have been night shift nurses. Intervention could have been having access to healthy food options during the night shift, compared to not having access to healthy food options in the night shift. And the outcome is that night shift nurses will have more energy to work their shift. That's one option. Here's another option for that same case study. So the population could be all night shift staff. It doesn't just be nurses. It could be techs or housekeeping or anybody. The intervention, having the cafeteria open for night shift employees compared to only having access to vending machines. And the outcome, more satisfied staff. So we really do have the cafeteria open in the evening for night shift at some of our locations based on this case study, based on this project that came out of the nurse residency. The next one, the night shift tiredness case study. Population could have been the night shift nurses or staff. Interventions could have been 20-minute power nap offered on every night shift that you work. So every single person gets the opportunity of having a 20-minute power nap, compared to not having a nap during the 12-hour shift. And the outcome could have been nurses will report more energy and that they're more productive. That's not the only PICO question that you could have had. You could have also had population could have been staff that work 12-hour night shifts. So you just reworded it a different way. Intervention is a 20-minute power nap only on the first shift, returning after being off work because of what's said in the literature, compared to never taking a nap at work. And the outcome could be nurses self-report less episodes of first night shift phenomenon, as you read in the literature. So those are just some of the examples. So what is evidence-based practice? So it has lots of different components to it. First, it has clinical expertise. So people who have been around a long time, who are working at the bedside, they have a lot to say about what works and what doesn't work. And that's sometimes where this all comes from. The next thing would be, there's no specific order. Research. So best research evidence. So going out and looking in the literature. And then third component would be patient values and preferences. So you can say a certain thing's going to work, and the literature could say a certain thing's going to work, but if your patients will not do it, then you really can't put that into practice. Let's look at some of the previous nurse residency projects.
So my NRP project was the post-op ileus prevention. It is now an order set. Basically, it is an order set for patients that have had certain types of surgeries to chew gum after the procedure when they're back up on the floor. And it helps prevent post-op ileiuses by helping them pass gas faster, have a quicker bowel movement, reduces their stay in the hospital, and improves patient satisfaction. We are now still doing research on if it is impacting the patients that are chewing it versus the ones that aren't. As a new grad working on the project, we had to go through the whole process of getting it approved since it was going to be an order set. So we started with the physicians and then went to the evidence-based team. We did all the research for it, and it was eventually added into an order set for several different surgeries. So it's something that I worked on as a new grad 4 years ago, and I still am working on it and see the changes throughout the system. And it's awesome to see the order set on the patients that I take care of.
Our NRP project is an emergency department aggression rating tool. We call it the EDART.
Yes.
It is a tool that we help assess and score our agitated, combative, maybe high, maybe drunk, emergency department patient. That we found a tool was for an ICU that was being modified, or a tool for an ambulance service was being modified. Not only did we find that there wasn't a tool for a specific population, there wasn't one in this hospital or another hospital or any hospital in America. So we're hoping to get not only this part of St. Luke's, like a tool to be used in St. Luke's, but hopefully around emergency departments everywhere.
The goal with it, we provided interventions for nurses to quickly recognize those symptoms or those behaviors and intervene to prevent escalating behaviors and reduce people going in restraints and increase safety for patients and nurses and all of the staff.
Yep.
Yes. How many people did you say there had been?
There'd been like 1,000, I don't know, it was like 1,300 activations.
Of either 2 or higher?
Of 2 or higher.
Okay.
Security had to come wand 57 of them.
Okay.
And only one of those peoples were in restraints.
That's awesome.
Yeah.
I never dreamed and didn't realize that so many different departments were involved in changing something that just involved one department. Like we're in the emergency department, and what we're wanting to do is for the emergency department, but we had to involve security and legal and regulation and research. And I would have never dreamed that all of that would be involved in process of change.
Wasn't just nurses.
No. We work as a team.
Yeah,
all
because I'm like,
anxiety.
That's refreshing you. Yeah.
Exhale.
Okay.
Okay.
We initially started with urinary retention and using peppermint oil to not prevent, but help urinary retention. And
We actually found that there wasn't enough research on that topic, so we had to broaden our horizons and do just like essential oils in general. But there is potential for us to complete research in the health system with peppermint oil and other essential oils.
Yes.
Yes.
What's the difference between research and evidence-based practice? Well, research, you're really focusing on discovery. So you're going out there and collecting information and trying to make sense of it. So some people call it investigating, but you're collecting new information and trying to find how they correlate together. And then evidence-based practice is really taking all that evidence and putting it into play, putting it into your clinical practice, applying it to what you do today. What are some barriers to evidence-based project? So if we have all this evidence out there, why aren't we doing everything that's the absolute best way to do it? Well, one of them could be lack of knowledge about what's in the evidence. So maybe they haven't read it or don't know about it. Another one could be individuals don't know how to complete a literature review or find literature. Another barrier could be research articles are challenging to read and review, and they are. Some of them are very difficult. Another one could be the time it takes the time to research and implement evidence-based practice. That's a lot of time it takes to implement something. It really does. And then last one, there's another one, this not knowing how to navigate the evidence-based practice process. So every place that you work, there could be a different way to implement. Even if you find out in the evidence this new way of doing something, how do you change practice at the place that you work? Here, we have steps for evidence-based practice project. So they don't necessarily have to go in this order, but this is a good way of looking at it. So you ask the question. So you look around at things that are being done and you say, I wonder why we do things like that. So you gather your team. So who wants to be on your team and help you with this project? And then you create a PICO. Okay, so once you get your PICO from the literature and to support it, create a plan or timeline. How long do you want to work on this project? Depending on what the project is, it could be very quick or it could take years. You're going to also brainstorm different terms for the exact same project. So we'll discuss that in another slide. So research the evidence. So you need to get as much evidence as possible, read it and evaluate it, and summarize your evidence. And from that evidence, then you can determine your recommendations. And then you have to look into how am I going to implement this evidence-based process. So are you ready? Let's go through the process together. You're going to ask the question. So you're going to say, why do we do it this way? You might go and look at the guidelines that we have already in place. You might look in Lippincott. It might have some explanations. You might look at different models that kind of describe it. But nurses usually say, that's the way we've always done it. That's a common response that you'll get, but that doesn't necessarily mean it's the best response. Another one might be trial and error. Why do we do it this way? Because we found out this is what works, right? One of them could be a guess. I guess this works. I don't know anything better. It could be that your peer told you or your friend told you how to do it like that. It could have been you got it from an old textbook. Only about 30 to 40% of the care that we provide is truly evidence-based, based upon the most current, up-to-date practice. Don't forget you got to gather your team. So for this particular project, the people that are going to be on your team are your peers in your nurse residency group, in your small groups. However, when you get ready to implement something outside of nurse residency, it could be anything. It could be people on your unit, people from your practice council, it could be different levels of care. Anybody who has a passion about the project that's being worked on should be on the team. It could vary greatly. So it could be your educator, it could be your manager, it could be somebody from quality, it could be somebody on shared governance groups, it could be somebody in leadership, or it could be somebody outside of nursing, like security. You have to come up with your PICO question. So you have to identify what is your population or the problem that you're trying to fix. What are your interventions? So what's the new thing that you would like to implement based on what you read in the literature and compared to what we're doing now? So you want to actually outline what it is that we're doing now and how is it different than your intervention. And then what will that bring to the table? So what is the outcome? So don't forget you have to write your PICO question. When you're doing this, you might look at a few different models. So some models of evidence-based practice and research is the Iowa model. So this was presented several years ago at the University of Iowa Hospitals and Clinics, and it highlights the importance of considering the entire healthcare system, from the provider to the patient to the infrastructure to using research as and practice guidelines. It talks about the number of steps and how to implement them. So the Iowa model is something that's really helpful whenever you're trying to decide, would this be a good project in an evidence-based project that you might want to do. So you can Google for this, or your clinical education specialist can provide this to you. Another model of evidence-based practice is the ACE STAR model. So it really doesn't tell you how to do your project, but it describes phases within your project. So early in your EBP movement, scientists try to develop different type of models, and this is one of the models they came up with. And so this starts out with, number one could be discovery or research. So it could be that you're doing collecting data as you go. And then evidence summary. So you're going to look at all the literature that's already out there. And then you're going to go in, look at the guidelines. So what do the guidelines say currently for you? And then you're going to try to put the new information into practice. So practice integration. And then you're going to measure the outcomes. Did it improve patient care? And so really you could jump on this in your project anywhere on the 1 through 5 area, but it's designed if you have nothing started to start with number 1. Our next step in the process is planning. So one of the great ways to do the planning is a timeline. So if you know when your due date is, start backing up from then of what you want done. So you want to be very detailed, like who's going to do what part of the project. Is each person going to take a different article and analyze it? Or is one person going to do all the articles and someone else do the recommendations? What would work best for you and your group? So it's something that you'll have to discuss for your project. Brainstorming. So think of every term that could possibly be used for your topics that you're looking for, because in the literature, they might not use the exact same term every single time. So let me think of some things. So I know that cell phone could be used for, it could say iPhone. It could say mobile phone. It could say, I don't know, all the different types of phones. Flip phone. I mean, there's lots of different words that could be used if you were going to talk about the importance of using communication with an iPhone or with a cell phone. So lots of different terms. All the terms you can think of, you should include that whenever you're looking through the literature. So once you decide what it is you want to look for, you need to search the evidence. So we are lucky enough to have all these different things. EBSCO, CINAHL. So CINAHL is very, very nursing focused. We have Medline, and we have the Cochrane. We have Ovid and PubMed and UpToDate and Lexicomp, but the best resource ever is our librarians. So if you go on to Citrix, you can find an icon that is either in ePulse, or you can find their own icon, which is Health Science Library. And you can click on that, and that will take you to an area that tells you how to do research. So as long as you know their email, so you contact the library, here's their email. You might want this for future reference. library@st-luke's.org. So you email the librarian your PICO question. You might also include all those other terms, and just put a paragraph in there. What is it you're trying to really look for? Besides just the PICO question, it might not be enough information, but if you really tell them what you're really trying to achieve, they're more likely to help you come up with different terms to look for. They're awesome. Once they've done a literature review for you, what they're going to do is they're going to send you back a big list in an email. Whoever emailed them first, they're going to send it back to that particular person. And the list of articles could be like 25 different articles. And what you do is say, you look at the names and the dates and the titles, the authors, whatever information you're looking at, and say, I'll take our article number 3 and 5. And they'll say, okay, I'll get those for you. Some of the articles they have to go and purchase. Some of the articles they have to borrow from other libraries. We don't have access to every single article, but we do have access to research for them. So sometimes libraries trade off articles. They have a subscription to a certain location to receive articles. Anyway, they do their magic and they get you the articles, usually within a few days. If you're doing it right now, and all the nurse residents are doing it right now, then they might take a few more days, because they also take care of physicians and interns and every department that they help them find articles. So the sooner you do it, the better, because then they'll have more time to help you. Once you receive all your articles, then you need to read and evaluate the evidence. So we're going to read them with the understanding that we need to figure out the level of the evidence. So we're going to utilize the American Association of Critical Care Nurses recommendations for levels A through M. The higher it is, the stronger the evidence. So let's look at some of these. Here's the AACN Pyramid. So A and B are both experimental. They're the highest level. A, B, and C all have evidence-based recommendations. D, E, and M are really experts' opinion, and they're not really experimental. They're just going to tell you how it is. So we're going to look at each one of these individually so you might be able to understand this just a little bit better. A, level A, is either a meta-analysis or a meta-synthesis. So a meta-analysis is a whole bunch of articles that put together, and they are quantitative studies. So we're looking at all the different numbers, percentages. This article said this, this article said this, this article said this. Overall, they're saying that the high percentage of X leads to this, B, X or Y, however you want to say it. So synthesis would be the qualitative studies. So usually if it's meta-analysis or meta-synthesis, it says so in the name of the article. I have an example there for you at the bottom. Level of evidence A, and then the name of the article. B is a very strong level of evidence. So this includes randomized control trials. So randomized control trials, also known as RCTs, but also with consistent results. So if I done this research in New York City and I repeated the exact same research in Texas, I would get the exact same results. If I repeat it again in Philadelphia, then I would get the exact same results. So it's very consistent. It's going to happen across the border. So randomized. So people they don't get to choose which group they're in, but they're randomized to control bias. Okay. And usually it's over time. So it's not a one-day thing. It's something you look at over a matter of time. So I have an example down at the bottom. Randomized control trials of interventions to improve communication in intensive care. So it gives you an idea of this particular one has it in the name about the randomized control trial. But just because it says randomized control trial doesn't always mean it's a level B. And hopefully we'll show you that to you in the next slide. Level C, usually qualitative studies. Sometimes they say we're a descriptive or correlating study. There could be integrative reviews or systematic reviews. They could be a randomized control trial, but they have inconsistent results, which means if I did it in New York City and then did it in Dallas, Texas, the results would not match, or they did not match previously. Or we can redo it in California or Washington State, and they wouldn't have the same outcome. That's why it's qualitative studies. If you say you're going to do research and say, what's your opinion about Ford Motor Company? What somebody says, maybe you survey 50 people in New York City and what they say. Then you take it to Dallas, Texas, survey another 50 people. The chances of both 50 people saying the exact same thing, having the same percentage of people who liked it, people who didn't like it, and the reasons they didn't like it, or the reasons they liked it, are very slim. Same with if you did it again in Washington State. The chances that you're going to have the exact same outcome, even if you randomly selected people from the audience or randomly selected people from the population, from a zip code, still would not get the exact same results. So if you could not duplicate the results into another location, then it wouldn't be a B. It would be a C. C's are still high. Level D, when we get to level D or lower, those are the lower ends of evidence, but they're still very valuable. So level D is a peer-reviewed professional organization standards with clinical studies to support recommendations. So that could be the Emergency Nursing Association's professional organization standards. So it may or may not have research behind it. We hope it does. It could be the American Heart Association recommendations, the diabetic recommendations from an organization. So it's a recommendation, but you haven't actually read the research yourself. Therefore, it'd be a level D because it's an organizational standard that they have published. E, it could be a multi-case study, or it could be one case report with an intervention and an outcome. So they could talk about, we had this one patient and they had one heart defect, and this is what we done for him, and this is what the outcome was. So it was one patient, a very small group. Maybe it's something very, very rare. And so therefore, since it was rare, you're not going to duplicate it multiple times. And you're not going to see it a whole lot. However, it doesn't mean that this is not valuable in our literature review. So it's theory-based usually, expert opinions that why they thought why this worked or why this didn't work or what we could have done better, all those things. Again, nothing wrong with including level E, but we were really looking for A, B, and C to be really strong. Level M, this is kind of a funny one. So your level M is your manufacturer's recommendations. And so if the Lucas, the chest compression machine that we have in the ER, the Lucas machined handbook might tell you to do a certain thing a certain way. So it's very biased to their product. It could be that our IV catheters, whatever their organization thinks that we should do for a certain method, it's very biased based on their product. However, that does not mean it's not valuable, especially if you're doing research or presenting a change in a certain product. You might want to include the manufacturer's recommendations. So if you're going to use the manufacturer's recommendations, you don't use them by themselves. You could just use them as a supplement with higher levels of evidence. So now we're coming to a time where we're going to practice analyzing literature. So I've collected a bunch of articles, hopefully have a little bit of a sense of humor to them, but each of them are different in different ways. And I want you to look at these articles and choose. Which one are they? A level A, a level B, a level C, a level D, a level E, or a level M, using the AACN levels of evidence. So you'll break out again in your small groups to analyze literature using the AACN model. I have provided your CES, your leader, with the answer key. So I'm not going to be going over it when you get back. Hopefully your small groups, you'll discuss the answers together.